Next, we're going to change gears a little bit, and our next speaker that I'm honored to introduce is from out west, Dr. Megan Fix. Megan grew up in a small town in Michigan, after which she attended Stanford for her medical training. Then she went across the country to Harvard for her emergency medicine residency, during which she was chief resident in her final year. She then joined the faculty at Maine Medical Center and focused on student education, then relocated back west to Utah, and she's been enormously involved in medical education at the student and resident level. And she is also the associate program director in emergency medicine for the residency in Utah. She is one of the leaders in the fourth year medical school transitions the internship course, and she's also the course director for the first year medical student clinical methods curriculum. So truly involved in teaching everyone from first year of medical school all the way up through residency and beyond. She's also a speaker at the heart course and the difficult airway course, and just an outstanding speaker on both emergency cardiology and neurology topics. So Megan, welcome to our cardiology symposium. Megan's going to be talking about challenging cases in Bradydysrhythmias. So welcome, and Megan, take it away.
Thank you so much, Dr. Mathieu, and thank all of you out there in the Zoom sphere for coming from far and wide all over the world to come to this symposium. I'm thrilled to be part of this, and I really also want to thank my co-speakers for amazing educational talks so far. So yes, we are going to talk about challenging cases of Bradydysrhythmias today. I have no financial disclosures, but I do have a personal disclosure. Bradydysrhythmias is really hard to say, especially many times in a presentation. So I may insert bradycardias from time to time. So we are going to do the following 4 things in the next half an hour or so. We're going to review Bradydysrhythmias and some key points that I think are really important when you're taking care of these patients. We're going to review some cases. We're going to watch a short movie, and then we're going to summarize. So let's get started. The way I frame this talk is I want you to think about being in your morning shift. Let's say you start at 6 or 7, you've got your coffee, you're scanning your board, and then somebody hands you this. So what's your first inclination? You're going to want to jump up out of your seat and go see that patient, right? And at first glance, you might think, well, bradycardia sounds kind of slow and boring, but as we see here, there's nothing boring about this. Going from this rhythm to asystole to arrest and death is not that far away. So for this talk, we're really going to be focusing on Bradydysrhythmias that make you get out of your seat and are potentially life-threatening. So you're running out of your seat. Hopefully you don't spill your coffee as you're going, and you get to the patient, and you're first going to ask these 3 questions. You're going to ask many questions, but starting with these. Is the patient stable or unstable? Is the rhythm narrow or wide? And as we all know, wide is definitely worse in the case of Bradydysrhythmias. And you're going to ask, are there P waves? But also, is there a relationship with those P waves to your QRS complexes? And the P and Q relationship is especially important in Bradydysrhythmias because we're going to talk about some blocks, and high-grade blocks really get into difficult territory there. So what is unstable, right? There's many things that can be unstable if the patient's not mentating well, their blood pressure is really low, they're in shock, they're having chest pain. But I'll tell you what it's not. It's not just the rate, right? The heart rate of 40 in somebody may be very different than a heart rate of 100 in someone else. So it's not just the number. And to highlight this, let's say we are at the University of Maryland Emergency Department and they say, Dr. Mathieu, you're needed in room 3. So Dr. Mathieu runs in there and he sees this gentleman, Michael Phelps, who actually is from Baltimore. He's also known as the Baltimore Bullet. So it's not impossible that you may run in and see this person. And he says, Dr. Mathieu, it's wonderful to meet you too, but my resting heart rate is 38. So clearly Michael Phelps in this situation with a resting heart rate of 38 is not unstable. He's awake, he's alert, he's talking to you. But key point number 1 is you're not going to know that unless you get out of your seat and go see that patient. And who knows, maybe for all of you at the University of Maryland, it might be Michael Phelps one of these days. So coming back to this case, you're going to get out of your seat, you're going to go see this patient, and you are going to do what every good resident knows about for oral boards, but also what we do in real life. You're going to place the patient on the monitor. You're going to get an IV or two. You're going to put them on oxygen if they need it. You're going to bring the crash cart in, get airway equipment to the bedside. But most importantly in Bradydysrhythmias is you're going to put those pacer pads on. You may not need them, but you want to get them on there. It's not going to hurt the patient. And that way, either you're going to need them or you're going to ward off evil humors. So here, I want to say that you're going to combine your medication. And so this is the key point number 2 for Bradydysrhythmias. You're going to jump out of your seat, go see the patient, and you're going to plan this dual approach, electrical and medical. And what that means right now is get those pacer pads on in case you need them, and we'll talk about the meds. This is the adult bradycardia algorithm from ACLS, and we're going to focus in on this box for a moment. Transcutaneous pacing and or dopamine or epinephrine is really what they recommend. And you'll see here, this is changed, and transcutaneous pacing and your meds, because you're probably going to need multiple things to help out in the case of a patient who's unstable with bradycardia leading to asystole and potentially arrest. So let's focus in on those meds for a moment and pacing. So atropine is underlined because atropine is what is recommended in almost all the algorithms as the first line. We used to say 0.5 milligrams to 1 milligram, but I would really recommend to you all to just go big with the 1 milligram dose and see what happens in a few minutes. Because actually, more likely than not, if it's a severe bradycardia that's causing instability, atropine may not work. It's totally okay to try it, but go big with that 1 milligram dose, wait a few minutes. If it works, then by all means, you can repeat up to every 3 minutes to 3 milligrams total. If it doesn't work though, I want you to quickly go down your algorithm in that dual approach, get pacing started if you've already had the pads on, which you should, and then remember epinephrine and dopamine are available to you. It's okay to use either one based on what you're comfortable with. I really prefer epinephrine these days because I think a lot of us are using it more often for anaphylaxis, for sepsis. Many of us have push dose epi either already mixed or we know how to mix it. So my personal approach is get those pacer pads on, try atropine 1 milligram while I'm getting the epi push dose ready, maybe give 1 to 2 mils of that while the drip is getting ready for epinephrine. I find epinephrine a little more routinely able to treat the other causes that we're going to talk about as well. You also have transvenous pacing available to you, but we don't have a lot of time today to get into that. So we're going to focus on the transcutaneous, which most recommendations are to start with first because it's readily available. So let's talk a little bit about why that atropine may not work. Here in the yellow is our lovely conduction system. And you'll see that all along the yellow, there's pacemaker cells there. And each of these cells has kind of an intrinsic rate that it likes to beat at. The SA node, if everything is well and good, is going to beat generally between 60 and 100 beats per minute. But if we knock out the SA node, and then we go down to the AV node intrinsically likes to beat more around 40 to 60 beats a minute. So let's say we knock out the AV node, and then we're down here in the bundle branches, in the ventricles. The ventricles are really not all about conduction, and they tend to beat around 20 to 40 beats a minute. And when you're getting down that low, that's where you lose your perfusion and your blood pressure goes down. So what I want you guys to think about is under this line, okay? Under this line is where you're in more trouble. So just like the movie Risky Business, the more trouble you're in, the less likely you're going to be able to get out of it. So when you're dealing with a conduction abnormality in the ventricles, and the ventricles are all you have to conduct your myocardium, it's wider, it's slower, and it's not as responsive to atropine. So atropine is a vagolytic. It works to decrease the vagus tone of the AV node. So atropine works right here at the AV node. So anything under this line, atropine is most likely not going to work. If anything is at this line or above, atropine may work. So again, it's worth a try, but don't be surprised, especially in your risky business territory of a very wide, very slow rhythm, atropine may not work. So this is what I initially learned. You get everything ready, the pads are on, you give atropine, multiple atropines, and then you wait, and then you pace, and then maybe you do epi. But what I'm going to really try and teach you guys today is that you want to do that dual approach from the start. And you want to think about many of the causes and many different medications and therapies that may be contributing to your Bradydysrhythmia. So you got your pads on, you're ready to go there with your electrical approach. And then in meds and other approaches, you really have to think about this key point number 3. Treat the underlying cause. Because not all bradycardias are just because of that conduction disease along that yellow spectrum we just saw. Some of them are toxicologic, some of them are environmental. And we're going to talk about them as we go forward. So here's our home base. We've talked about what you're going to get ready and what you're going to do after you jump out of your seat and go see the patient. The pads are on, and you're going to ask these 3 questions. Then we've already talked about the treatment from ACLS. You've got your atropine, you've got your pacing ready, epinephrine, and or dopamine. These are the causes we're going to go through. I like to think about these 5. Ischemia, hyperkalemia, drugs, and there's 4, the Brady bunch. Beta blockers, calcium channel blockers, clonidine, and DIG. Then we also have hypothermia and hypothyroid. They cause bradycardias too. And finally, don't forget, the brain can cause bradycardias. Cushing's reflex, remember, is bradycardia, hypertension, and abnormal respirations. And so that in and of itself can lead to bradycardias. Remember this yellow as we go through the cases, guys, because other is all the other therapies that I want you to remember. So armed with that, let's dive in to our cases. So our first case is a 90-year-old man with recurrent syncope. He actually had 5 episodes of syncope before coming in. I got this case from one of our former residents who's now graduated, Dr. Paul Yiannopoulos. He is now practicing up in Maine. So of course, Paul did the right thing. He's a moonlighting resident during this case, but he jumped out of his seat, ran to see the patient. The patient was talking to him and stable for the time being. And then he said, well, is it wide or narrow? And if you look, you see some wide beats that are ventricular escape. Then you see some narrow beats, which are junctional escape. And they're intermittently going at a rate of around 30 to 40. So Paul gets the pads on. Of course, he's got epinephrine ready. He's got atropine ready. He gives atropine. And then as he's getting ready for the epinephrine, look what happens. The patient deteriorates into only ventricular escape beats. So this is definitely risky business territory. It's wide. It's very slow, around 30. So what's a moonlighting resident supposed to do, everybody? Well, he appropriately transcutaneously paced the patient. So I'm going to show you a few slides from one of my friends from Maine Medical Center, Dr. Jeff Holmes. He has a great blog post on transcutaneous pacing. So I highly recommend you go there and watch the video as well as the slides. So we're going to cover his 5 steps briefly. Number 1, place the pads on. You've already done that. But don't forget sedation, because the patients are going to be uncomfortable during this procedure. You've all probably seen this, and it's really painful to watch. Step 2, you've got 3 dials on most of your pacers. First step is put it in pacing mode. Third step is your second dial right here. Set the rate, generally 60 to 70. Okay, that's usually enough to perfuse your patient. And then finally, step 4 here is your last dial. That's your amperage. You're going to turn that up slowly until you get consistent electrical capture. So electrical capture is what you see on the monitor. You're supposed to see this, a pacing spike with your QRS, pacing spike, QRS. When that consistently happens, that's electrical capture. But don't forget step 5. You have to confirm mechanical capture, which is what's happening in the patient. So you want to feel their pulse. You can all check with a pulse oximeter. Those are the 5 steps of transcutaneous pacing. But remember, guys, this is only a bridge. You're not going to send someone home with a transcutaneous pacer, but definitely know how to use this in a pinch. So next case is a 67-year-old man with chest pain. And it's not hard to see that there is a huge inferior STEMI, right? We got tombstones all throughout the inferior leads. But since this is a bradycardia talk, I'm going to focus in on the rhythm. So remember the quick and dirty way to check your rate. And the residents, especially when you're doing an exam and they don't give you the rate for the ECG, Most ECGs are done in a 10-second cycle. So you can count out the number of QRS complexes and times by 6. So let's do that. 1, 2, 3, 4, 5, 6 times 6 is 36. So that is quite bradycardic. And in this case, it's actually the ischemia from the STEMI that's causing the bradycardia. I've left these arrows up here so you guys can review. You have P waves. They are marching out to their own drum here in the red. Then your QRS complexes, and they are wide, so this makes us down in risky business territory, they are also marching out to their own drum. So what is this? This is third degree AV block due to STEMI. And this happens. So why does this happen? Let's review on this anatomy slide for just a moment. So in inferior STEMIs that are due to the RCA here, let's say you have a blockage of this artery causing your inferior STEMI. This small artery here actually feeds the AV node. And what responds or what acts on the AV node, remember from a couple slides ago? Atropine. So actually in cases of inferior STEMI where there's ischemia to the AV node, you can oftentimes use atropine and it will likely help. It's also transient because once you open up this artery, hopefully by getting the patient to the cath lab, then you will perfuse the AV node again, and it will hopefully get rid of the high degree blocks that you're seeing. If you have an anterior STEMI over here, not so great luck with the atropine, but an inferior STEMI, most likely you'll be able to use it. So if you have bradycardia due to ischemia, get those pads on, but try atropine and it might work, and hopefully it will work in the case of an inferior STEMI, but don't forget about your STEMI meds and getting the patient to the cath lab. So our next case is a 68-year-old man who is feeling weak. This case I received from another former resident, Tabitha Ford, who's now practicing in Vermont. And she goes in to see the patient because she jumped out of her seat, of course. And the patient is slightly confused and only at a rate of around 24. Remember, 1, 2, 3, 4 times 6. That's really bradycardic. He has a very, very thready pulse and a very low blood pressure. And oh, by the way, he missed dialysis. So this is a case of hyperkalemia. And I love hyperkalemia just as much as Dr. Matu does, the great masquerader. But this is something that I think we don't talk about as much in regard to hyperkalemia, is that it can just cause bradycardia. Yes, the QRS is wide here and the T waves are sort of peaked, but they're not peaked like you would not want to sit on them. And it reminds me of a case that I had when I was a resident, and I will never forget it. It always burned this into my brain. It was a case of a bradycardic patient with an ECG very similar to this. They were very bradycardic, and I was an intern, and I thought, I got this. I took ACLS. We had the pads on. We gave them atropine, multiple doses. We started an epinephrine drip, and the patient is just not doing well at all. So finally, one of my astute co-residents lifted up the gown on this sim mannequin and found the moulage fistula. So any of you educators out there, this is a great case to do for resident sim, but I will never forget it because obviously it was hyperkalemia. And what was the therapy that we were missing? Calcium. Absolutely. So we gave calcium, saved the sim mannequin, but this is a great reminder of why you need to use your brain and think about what is causing your bradycardia. And actually, after this case, the attending who was running it said to us, residents, never let anybody die in the hospital without receiving a dose of calcium. And I get it. If there's bradycardia due to hyperkalemia, you don't want to miss out and forget that calcium. So just try it in the situation where the patient might be in renal failure and have hyperkalemia. So this is a great case from a friend of mine, John Hendrick, who works with me at University of Utah. This is a real get out of your seat case. So he gets handed this and he jumped out of his seat so quickly. You might be able to see on the ECG, he actually spilled his coffee on the way. But you can see why. This is an extremely wide, very bizarre, terrible looking, almost sinusoidal case of hyperkalemia. So Dr. Hendrick did the right thing, gave the patient calcium, and you can already see the bradycardia is resolving and the QRS is widening. And there's only a very small bit of coffee on the second ECG, so that makes us feel better as well. So don't forget hyperkalemia. I always like to think wide, slow, or bizarre. And that will prompt me to give calcium. So if you see a wide, slow, or bizarre ECG, plus minus a melange or real life fistula, don't forget to give calcium. Okay, moving on to our next case. This is a 17-year-old female who presents with an overdose. There's lots of toxicologic causes, as we mentioned, for bradycardias. So looking at this ECG, she's a 17-year-old. Let's see what her rate is. 1, 2, 3, 4, 5, 6, 7, around 42. So probably abnormal, right, for a 17-year-old. And you'll actually see she's narrow and she does have P waves. So she's actually in a sinus bradycardia. But as Dr. Dory, who's our toxicologist who gave me, toxicologist at Utah, she gave me this EKG. She went to talk to the patient and the patient said, oh, by the way, I overdosed on 247 tabs of clonidine. So clonidine is one of the Brady bunches that I don't think we talk about as much. So that's why I wanted to bring it up here. Pacing is not going to help in this case. Epinephrine actually may help. So they did try that. And she was on an epinephrine drip for a while, but naloxone is the key here, everybody. Naloxone is the antidote for clonidine overdose and very high doses, actually. So in this case, they ended up giving 10 milligrams IV. You can actually also sometimes do an naloxone drip. So don't forget about that one. Here is a quick case that came up in our recent case conference. So Forrest Wells, one of our residents, gave this to me. This is actually tachycardic, as you can see. Here is flutter waves going along through, and this patient was quite hypertensive, actually, and tachycardic, so they wanted to decrease his rate. So the patient got multiple doses of IV metoprolol over a short period of time, and actually went into something like this. So this was an accidental metoprolol overdose, and you can still see the flutter waves here, but he has a very slow ventricular response, and he was becoming hypotensive. So beta blocker overdose, you have to think about as well. There are tons of beta blockers and calcium channel blockers out in the world. And in this case, atropine was transiently effective. Epinephrine was also transiently effective, but really the treatment, they gave multiple doses of IV glucagon, which is specific to beta blockers. And then don't forget all these other therapies that we have available to us now with beta blockers. So summary for these toxicologic causes of bradycardias, the Brady bunch is beta blockers, calcium channel blockers, clonidine and DIG. Pacers and atropine may not work. And it's just as in the case that I had. I was flogging this sim patient with atropine and epinephrine and all these things and totally forgot about calcium. Don't forget about your antidotes, okay? And involve your friendly toxicologist to help you in the cases of overdose. All right. Our next case is a 70-year-old woman who I saw quite a few years ago. She was weak and cold. And I ran to see the patient. Maybe not run. I probably walked. But she was stable, actually. She had a blood pressure in the 80s, but she was talking to us. And if you look at her ECG, she's quite bradycardic. It's not quite wide, but then you look and you don't really see any P waves. She was in a junctional escape. And her reason for her junctional escape turned out to be hypothyroid. She was profoundly hypothyroid, and we ended up needing to give her thyroid hormone. And in this case, epinephrine probably would have helped because it does support the blood pressure, but atropine would not have helped. And so giving her thyroid hormone was definitely important. So this is a 65-year-old man found down in an alleyway. This was also an ECG from Dr. Dory. And he is bradycardic around 60, but if you look closely up here, I'll blow it up for you. This is what Dr. Dory found. These are Osborne waves or J waves of Osborne, and this happens in hypothermia. So hypothermia is definitely a cause of bradycardia. No degree of pacing or atropine is going to fix this, right? So you actually need to warm the patient. And that's what Dr. Dory did. And the patient got better. So hypothermia and hypothyroid are out there. Remember, you're treating the underlying disorder. So finally, this is a case I saw last year. We got a report from EMS that there was a 35-year-old patient coming in with a heart rate in the 40s. He had had syncope at a concert. So we get ready, we have our pacing ready, we got our atropine, we got our epinephrine. He comes in and he's actually in a sinus bradycardia around 40. And my astute resident was doing a really good history and physical and saw this, a blown pupil on the right side. And he was definitely becoming more altered throughout transport. So what was this? This was a large epidural, and this is the Cushing's reflex. Remember, bradycardia, hypertension, and abnormal respirations. So this patient did not need pacing, did not need atropine or epinephrine. He needed to go to the OR, and that's where we got him. But again, a good history and physical is what diagnosed this case of bradycardia. So don't forget, treat underlying disorders. So no talk on bradycardia really would be complete if we didn't mention this gentleman. This is Dr. Wenckebach, and it's definitely hard to spell, but it turns out is really fun to sing. I'm going to show you a quick video from the med students at the University of Alberta in Canada. And hopefully one of you out there from Canada actually made this video now 10 years ago. Let's watch.
Diagnosis went get back.
What?
It's AV nodal block, and that's a fact.
Yeah.
Take PR interval and lengthen that. Bradydysrhythmia and heart attack.
Oh no. Take it to the node.
Okay, I could watch that video all day long. It is still, after 10 years, one of my favorite YouTube videos. I highly recommend you guys check it out. Here are the lyrics, and it's actually quite educational too. So kudos to all of you who did that video from the University of Alberta. So Wenckebach is definitely a fun rhythm, but it's not as concerning as these other two. So we're going to focus on second degree type 2 and third degree AV blocks, as we already saw in a previous ECG. This is a 66-year-old woman with recurrent syncope. She had been to the ED 3 times, and on the third time, she had fallen and got an orbital blowout fracture. So my friend John Ryan, who's our cardiologist, he went and saw her as a consult, and this is what we found. She has a P-wave, QRS, P-wave drop, P-wave, QRS, P-wave, QRS, P-wave drop. So this is second degree type 2, and I just wanted to point out in type 2, the PR intervals will actually be the same, whereas in third degree AV block, they are going to vary because remember the P's and Q's are beating to their own drum. So the treatment for this is a pacemaker. And all of you astute clinicians out there, the whole point about mentioning second degree type 2 and third degree AV block is that the definitive therapy is a pacemaker and admission. And the only way we're going to get there is if we diagnose the condition first on ECG. And this is my final point, is that you are all smarter than the computer. So I'm going to show you a couple of examples of how you are and how you can diagnose these high-grade blocks and save the patient. So this is from a friend of mine, Dr. Eric Schenfeld, who's over at our community hospital, IMC. And this patient he jumped up to see the patient. He went in, he saw that it was a wide QRS, saw the P waves, and closely looked at these P and Q relationship. And he said, here's the Ps. They're marching to their own drum, and here are the QRSs. So Dr. Schenfeld appropriately diagnosed this as third degree AV block and got the patient admitted for a pacemaker. However, what did the computer say? Marked sinus bradycardia with complete right bundle branch block. Well, I'm really glad to know about that right bundle, but I would have been sad if we sent the patient home with marked sinus bradycardia. So be yourselves. You all are smarter than the computer, even still in 2021. Final case of this is another one by Dr. Schenfeld. He jumped up, saw the patient, they were bradycardic, and he's looking closely. It's not really wide. He's looking for P waves. And what does he see? P wave, P wave, P wave hidden here, P wave, P wave. And the QRSs again are marching to their own drum. So of course, Eric diagnosed them with third degree AV block, got them admitted, but what did the computer say? Well, the computer had a lot of opinions on this ECG. Sinus rhythm with complete heart block and idioventricular rhythm. I think this computer has a little bit of radiologist in them because they can't really make up their mind. Maybe we should add in clinical correlation advised next time, or maybe at least put complete heart block first, since that's the most deadly. So bottom line, you guys, the summary that I have for you for bradycardias for this morning is: number one, get out of your seat and go see that patient. Number two, plan for an electrical and a medical approach. So get those pads on right away. And when you think about your medical approach, think and treat the underlying cause. That can involve your atropine and your epinephrine or dopamine, your pacing, but also calcium and your antidotes. And finally, remember, you are all smarter than the computer. Thanks so much. Here is my email. Please feel free to email me with any fun cases or comments. And thanks again for the opportunity.
All right, Megan, thanks so much for your time and for a great lecture. I wasn't sure if you were going to mention dual sequential pacing as a homage to Corey, so hopefully that's not out there. Let me hand things over to Cheyenne and Sarah for some questions that came in.
Thank you. That was wonderful, Dr. Fix. Appreciate it very much. So there were a lot of questions actually about naloxone as an antidote for clonidine overdose. So first of all, how does it work? And then you mentioned that you can give it as a bolus and possibly as an infusion. So what's your practice in terms of when you would do a repeat bolus dose and when your trigger would be to start the infusion?
Thanks, Dr. Dobbs. That is an excellent question. And I have to have disclosure. I am not a toxicologist. So what I would first do is call my toxicologist and look it up. In regard to the case that I presented, this patient had taken a lot of clonidine, almost 250 tabs. And so initially, actually, I didn't mention in the case presentation, but initially she was hypertensive, which you can see with a clonidine overdose, which I don't understand the mechanism, but she was initially hypertensive. So they had her on antihypertensive therapy. Then she went hypotensive. And throughout that whole time, they were giving intermittent boluses of naloxone. So it wasn't a 10 milligram bolus per se, but it was intermittently giving 1 or 2 milligrams. And then it started working. And then they went on the drip. So this is not something that I think has a gold standard approach. I'll have to look it up after we're done this morning, but it's definitely something you got to think about, because at first glance, an overdose, I wouldn't think, wow, I got to get my naloxone ready. But absolutely for clonidine, that's going to be your antidote. And remember, for the Brady bunch, there are some great lectures out there about these different toxidromes. And the approach has changed over the last 10 years, where really in a very sick person, and I've seen super sick people with, especially propranolol overdose, when they seize, you got to intubate them. But you are bringing everything to the table in that case. You're doing epinephrine, you're doing high dose insulin therapy, you're potentially doing interlipid, you're also doing glucagon, and you're also doing maybe even ECMO, which I didn't put in the presentation, but these can be very scary overdoses. So I went a little bit off tangent, but yes, naloxone, I'll have to look it up, but it's definitely the preferred therapy for clonidine overdose. Great question.
Thank you, Dr. Fix. We have one more question before going on to the next speaker, and then we'll save some more questions for you for the Q&A session. But we have a question actually coming from one of our other speakers today, Dr. Slovis, asking, is it optimal to wait 3 minutes for the atropine to work, and why not sooner?
Great question, Dr. Slovis. So in ACLS, yes. But I've done some reading on this, and there's actually a really great blog post on this on the EM Crit site that talks about the mechanism of atropine and then epinephrine and why epinephrine should be preferred. So if atropine is going to work, the pharmacology of it is it should work in the first few minutes. It should work within 2 to 3 minutes. So then that's why I believe in ACLS, it's recommended to repeat after 3 minutes. But I think only if it works. Only if it works, you should give it, because there is some literature, especially in ischemia or some other dysrhythmias, where if you give too much atropine, it can actually reflexively have a bradycardic effect. So my personal opinion is to give the 1 milligram dose up front, wait 2 to 3 minutes as you're getting your epinephrine ready. But if it doesn't work, don't give it again.
Thank you.
All right. Well, thank you very much, Megan. We'll be back with some good questions for you at the panel also.